horizontal common strabismus. As we all know, unpredictability is always a problem in strabismus surgery. And to reduce that, in 1885, adjustable suture surgery was introduced, which was again made popular by Jampolsky. It gives the surgeon opportunity to place the eye in desired position even after the surgery. It is based on the principle of temporarily securing the suture so that it can be undone and the muscle is allowed to slip back or brought forward according to the alignment which is needed. Can be done in these three methods: Bow-knot, Singh suture or bolster method. It is basically indicated in any cooperative patient, especially if the outcome is unpredictable and we need a precise alignment if fusion potential is present. It has various studies have shown its definite role in paralytic strabismus, restrictive strabismus, and thyroid ophthalmopathy. But there are few studies which discusses its role in comitant deviation. So the aim of our study is to compare the surgical outcome of adjustable recession with conventional non-adjustable recession in patients of horizontal comitant strabismus. It was a prospective tertiary care center-based interventional study and was conducted for 1 year. All the patients were more than 8 years of age and underwent squint correction surgery for horizontal comitant strabismus were divided randomly into two groups. First group was AS group, in which 27 patients underwent standard limbal conjunctival approach adjustable suture recession using shoelace knot with conventional resection if required. And the second group was non-adjustable NAS group, in which equal number of patients who underwent surgery with conventional non-adjustable suture resection or only recession for similar conditions. The adjustment was done 24 hours after the surgery under topical application, that was proparacaine 0.5%. The patients with history of previous strabismus surgery and history of intramuscular botulinum injection were excluded from the study. The results were mainly assessed in terms of requirement of suture adjustment in AS group, successful outcome which was defined as horizontal deviation less than or equal to 10 prism diopters on either sides of orthoporia at the end of 6 months, and any complications during or after the surgery. Observations were, these are the pre-operative summary of clinical data which shows almost comparable groups. Post-op summary shows in there was decrease in mean angle of deviation at day 1 and at 6 months, and the resurgery rate was reduced in AS group, and there was marked improvement in successful outcome in adjustable suture group. These are the graphs showing angle of deviation. It is reducing in both the groups, and it is better in AS group than in NAS group. Post-op adjustment was done in 48.14% of patients in AS group. All were done for overcorrection. There was no suture or adjustment related complication in either group. There was only one patient who developed tenor cyst in AS group. Supramaximal, there was also one observation that supramaximal recession for large angle squint were performed, and it was not associated with motility restriction and palpebral fissure anomalies. This is the photograph showing patient of tenor cyst which underwent excision of the cyst. These are few photographs which shows in pre-operative there was infantile esotropia. Post-operative photograph shows overcorrection, and post-adjustment it shows orthopsia. This is also tropia. Post-operative picture shows overcorrection, and post-adjustment shows orthophobia. The main limitation of my study, it was a small sample size and there was heterogeneity introduced, as there were both esotropia and exotropia safely performed in selected patients of comitant strabismus, and it can also be done for large angle. a wider use of adjustable